Hello, everybody, and welcome. We're glad to see you all, whether it's morning, afternoon, evening, or nighttime, where you are. A very warm welcome. I'm going to share screen as folks start to trickle in. And so we'd like to extend our warmest welcome to this session, which is the first in our Resident Reviewer Development Program and International Community Curriculum for the 2022 year. I'm Jennifer Shin. I'm from Boston, and I'm Miss Corinne Spriggle. So today, we're going to be focusing on an introduction and approach to peer review for clinicians. And we've specifically set this up because we realize that for most folks who will join us at the journal, seeing patients, it's a straightforward thing. But peer review, especially as you're beginning, whether you're beginning with us in the Resident Reviewer Development Program, or you're joining us as a member of our international author audience, it might seem a little bit more foreign. And so what we want to do is try to present peer review in that context as something that's quite familiar. And so this year marks our sixth. It's really exciting to see. We've enrolled successfully 5 cohorts previously. In 2022, we saw our all-time high number of applicants, and it seems to be indeed increasing. And so Corinne has been feverishly working on the mentor-mentee matching so that we can establish our 2022 matriculants. Our goal in establishing the matriculant list is really to try and ensure that we can include the most number of people possible and also try to get everyone started at about the same time. So we're just about in the high 30s at this point, but we're hoping that we're going to be able to solicit some additional mentors so that we can cover more of the group. So stay tuned, all of you who have applied, and we think we'll have the formal matching list quite soon. And for those of you who are international colleagues, we also extend a very warm welcome. So for those of you who do matriculate into the Resident Reviewer Development Program, we do ask that you read and watch the training materials. And Corinne has a link that you can go to for this website. And you'll also see that there's just a checklist in here, thinking about the different resources and making sure that you hit them all in terms of training. Since Corinne has been elusive with sending me a headshot, despite the fact that she knows I love to extol her great work in these sessions, I have to simply state I love Corinne, and we all love Corinne. And as you join the program, you'll get to see how absolutely fantastic she is and all the work that she does. So one thing that's been really exciting for us in the Resident Reviewer Development Program is that we've been able to form such great connections, and globally. This beautiful graphic from our Academy staff shows all the mentees and mentors and some of our graduate mentees and mentors. And you can see how far they are spread, not just across the US, but really across the world. When we get together for various meetings, we actually have to consider that folks are actually in New Zealand and 13 hours ahead. So today we're going to focus in on this introduction approach to peer review for clinicians. And today our goals are to think about our Otolaryngology head and neck surgery journal and our sister journal, Oto Open, and the mission, ethics, and standards, and the importance of really understanding the current literature when crafting and developing a manuscript and reviewing a manuscript as well. And we're also going to go through some criteria by which reviewers could make recommendations, getting into a very specific framework that's designed for those who have primarily a clinical background. And so to open for us today, I am so pleased that we are joined by Dr. Erika Celis-Aguilar. Dr. Aguilar is a professor in Mexico, and we were actually just talking about what a favorable environment she is in. Folks who live in Hawaii will actually come to Mexico for a vacation. And in addition to that, We have a wonderful otolaryngologist there in Dr. Aguilar. Dr. Aguilar is an otologist, a neuro-otologist, and has been such a wonderful addition to our journal team. She was a star reviewer back in 2014 and has continued to contribute in so many ways, whether we're developing international curricula like these or training folks within our resident reviewer development program. We've just been so fortunate to have you. And so I'm going to turn it over to Dr. Celis next.
Thank you so much. I'm honored to be here and be part of this great project. Thank you so much. And now I want to talk to you today about the introduction to peer review process, being part of this great program. And the first question that arises is why review? I think we review because we want to be in academic medicine. We want to hear of the latest news in science, and also because we want to be readers, great readers with analysis, with a great capacity to evaluate literature and to know exactly what is the news in science and how can we apply this to our patients and to clinical practice. So above all, also to be a good reader means to be a good author. This is an ongoing process, going back and forth, being a reader, and in that particular moment, to understand how to be a good author and to know how to write a great manuscript. So we do want to know how to improve the quality of published science. Sometimes you overlook the job of the reviewers and the editors, and we do have something to say about improving the quality of the manuscripts once it reaches the final stage. So what are the requirements of the reviewers? I would say that one of the first requirements is to be non-biased, unbiased review, and to be an intellectual equals. Some of you that are residents, you will say, well, similar qualifications to senior authors, probably. How can you get those same qualifications? I will say the through literature review can give you the keys and all the tools to review all the manuscripts that can send to you by the office, editorial office. Also, it's very important to know about research methodologies, which this course can give you some of the tools to improve your analysis on this research and materials and methods. And it's important for you to know that the higher the impact the journal, a journal such as this, one of the top journals of the otolaryngology, has more strict criteria to the acceptance of manuscripts. Also, the reviewers' qualifications, they need to have a good communication skills with the editorial team, with the associate editor, and also with the authors. They need to be professionalism and skills to perform and synthesize a literature review. All this will give you a better practice with your patient. By the knowledge obtained, you'll have a greater practice, and all based on scientific evidence. So this journal is a journal of the American Academy of Otolaryngology and Neck Surgery Foundation. And the mission of this journal is to give contemporary ethical and clinical relevant information in otolaryngology, head and neck surgery. And it's based mainly on clinical evidence. We do publish basic science research, but with a clinical standpoint, because this knowledge will go to the otolaryngologists, clinicians, scientists, and specialists devoted to improve patient care and public health. This slide was a previous slide used last year, and I was saying previous to this talk is the impact factor was 2.3, and now with this have a new impact factor now for this year, which is amazing. It's a terrific job by the editorial office with an impact factor 3.4. You can see here that is one of the greatest journals in otolaryngology in our specialty, 5 out of 44, and in surgery, 55 out of 212. You can see here in Scopus also one of the greatest journals available in this worldwide. So what type of manuscripts do we accept? Right now, there are original research, patient safety, systematic review, meta-analysis, state-of-the-art review, commentaries, short scientific communication, clinical technique and technologies, case reports, which they really have to be a novel to get published in this journal, clinical photographs, and letter to the editor. So how this reviewer process goes? First, the author needs to fulfill all the manuscript guidelines for the author guidelines, and then the editor-in-chief sends the manuscript to the associate editor, the two reviewers. There are usually two reviewers, there can be more. And once the reviewers have sent their recommendations, these go back to the associate editor, which gives a recommendation by himself or herself, and then the editor-in-chief decides if this manuscript is accepted or not, or rejected, or to follow the recommendations of the reviewers and the associate editor. But he has the final decision. How the review goes? Well, the single blind review, this is the form that we're using in our journal, which means that the authors don't know who the reviewers are, but the reviewers do know who the authors are. In this part of the process, you will get the manuscript and you will know if it's a domestic submission, which is in the United States, or international submission, and you will know exactly who the authors are in all of the authors. So the double blind review means that neither the author nor the reviewers know themselves. They don't know their identities. And in the open form, both know who they are. So this is a great question, how to start a review. And I guess you're thinking that by yourself too. What is the best way to start a review? First, you will need to have a timely review. I will say that the invitations should be accepted or rejected within 3 days, and the review should be done on 10 days maximum. So the earlier, the better, the review. So, and how to start a review? Well, there are different points of view how to approach this. Some will say from the methods section, they will just read the methods and see if they fulfill all the study design, the sample size, and will know exactly if this manuscript is worth publishing by the Otolaryngology and Surgery Journal. Others will just go and read the whole manuscript, and after very careful review will decide on that. And this is how to start a review. And the others will just read the abstract and see how the manuscript is going, what new evidence is showing, if it's worth publishing or not. Obviously, all the reviewers will read the whole manuscript, but this is how it will start the review. I will say that I will start from the abstract. I will start from the abstract. I like to do that. I like to read the abstract and later go and read the whole manuscript. But before I do that, I would like to after the abstract, go to the review of the literature. And after reviewing all the literature, I will just get the context of the study, get the context of this scientific evidence, see how other authors have approached this problem, also see how the study designs were made, if this was or is a unique contribution or not. This is very important to get into context because they give me the exact weight of the investigation, of the research. I think when you get the submission, when you can get the submission of the article and you can make the recommendation, there's a part of the platform that says view similar articles in mainline, so you can just go ahead and click on that and see all the manuscripts that are related to your research and see if this is a unique contribution or not. So these are the questions the platform also asks of you. And one is very important. The number one is relevance to mission. I will say that if you answer that question, you mainly know if the manuscript will get published by the Otolaryngology and Surgery Journal or not. And this is, can the information of this manuscript can be used to improve patient care and public health? This is very important. Remember that this is a clinical journal and we're very interested in improving our patients' lives. Other very, very important question is internal validity. And this is about the study design, the conduct, the analysis, if this is described appropriately, if this is unbiased, if this is reproducible. And so you can see here some of the guidelines that are followed by the journal, which is systematic review, meta-analysis, follow PRISMA, randomized clinical trials, follow CONCERT, animal preclinical studies, follow ARRIVE, and quality improvement Squire. So these are the guidelines you have to get used to and get and read them. So know if the journal, if the manuscripts are following the journal's instructions. And this is one of the example of the CONCERT guideline. You can see here um, what is some of the examples. You can see the background and objective had to be described, the trial design, the participants' intervention, and the outcomes had to be very well designed for randomized control trial. Also, the sample size has to be determined, and the formula, if it has one, it has to be described on the manuscript. The randomization, the sequence generation, and the allocation are very important. Also, the blinding, if there was one, has to be greatly described. And there are other samples here in the results. We're going to see in the next slide the flow diagram, the recruitment, the baseline data, the outcomes, the primary, the secondary outcomes, the harms. In the discussion, there has to be the limitations, interpretation to see if this is a good randomized clinical trial manuscript. And here you can see the flow chart of the CONCERT diagram. And you can see here the eligibility of the patients, how some of them are excluded, how some of them are randomized from allocated from one intervention to another. And there's also a description of the patients lost to follow up, as you can see here. And finally, the patients analyzed, which are at the end of the flow diagram. And this is an example of the PRISMA systematic review. I think it's very important from systematic review how the studies are selected, what information sources you use, how the search strategy was made, who made the study selection, for what terms they make the study selection, the data collection, and etc. The other question is the external validity, and this means how the sample was chosen, it was appropriate enough, if it was adequate, if it's described in adequate detail, and this means that the results can be generalized. Remember, if the sample is not described correctly, or the sample is not enough, it's a small sample, the results is very hard to get the result generalized worldwide. It just means that a small sample is to just describe a small population in a very local way. And this is a very important key point. This is ethical conduct. Remember that a manuscript has to be approved by the International Review Board. Almost all hospitals have this International Review Board, and has to be free of undisclosed conflict of interest. If there is some conflict of interest, the authors have to disclose them. And also the patients had to sign informed consent. Also very important is the level of evidence. How I said before, these manuscripts really has to improve what is already known about a particular subject. And inconsistency, if a manuscript has inconsistencies with previous literature, that's why the review of the literature is so important. If there is consistency, you have to double check the manuscript, you have to double check the material methods, and be sure there's no error, there's no missing data, there's no error in study design, or how results are described. So you will not get biased by these results, and be sure this really portrays what the scientific evidence is all about. So the recommendation is could be accept, minor revision, major revision, reject, or reject and refer to auto open. In the accept, it's very few works, a manuscript that you will have, it will go directly to accept. This means that the manuscript has no errors. It means that it's very greatly written. The subject is relevant, and the topic is new and novel, and it may be used to improve patient care. This is very few manuscript will go to here. But minor revision, this means the work has only minor problems, and once corrected, it can go and publish by the editorial office. Major revision, on the other hand, the manuscript has major concerns on ethics and study design, the results, the general stability of the findings, or the manuscript probably has some uh, grammar problems, or there has to be some of the revised corrections to get into minor revision if there is some other corrections missing, or acceptance. Only 50% of the manuscript that will go to major revision will get accepted. Rejection is when a manuscript has fatal flaws. This means there's ethical concerns, the sample size is very small, the study design is incorrect, and therefore you have to reject this manuscript. There's other option that you can reject when the manuscript is well done, the topic is good. I mean, it's novel, it's interesting, but the sample size is small. For example, you can refer this to Auto-Open. Actually, the authors get discount if they get referred from Otolaryngology journal to the high journal to the Auto-Open. And it means that it's interesting study, but not maybe generalizable enough, or it has some inconsistencies. So probably the sample size is not so well done. When you submit recommendations, there's a score from 1 to 100. 100 is the best score. 1 is the least score, is the worst score. So you will get to, besides the recommendation, you have to score the manuscript and say, what do you think the score is from a well done? I will say a well done manuscript will go to 80s, 90s. And when it's major revision, probably 60s. And when you give these comments to the author, you had to do this very constructive. Remember that our goal as reviewer is to improve the manuscript, even if the manuscript is rejected. I think our goal is to make science, and we as reviewers, we can make science with the authors. We can improve science. So remember always to be very constructive. And when you give these comments, remember, you're blinded, they don't know you, that they won't know your name, but it's still, you could get very constructive and improve all the flaws of the authors. And maybe with that, they will get, published if they get accepted, if they get all the corrections you made. So also, you need to be very careful that the reviewer to editors are very congruent with the reviewers to authors. If you think there's a fatal flaw, if you suspect plagiarism, you suspect there's something missing, some inconsistencies, if you won't tell them to the authors directly, you can go and tell the editors. But if you think this is a very well manuscript, then those comments should reflect the comments of the authors. There need to be similarities in both comments. Obviously, as a reviewer, you get to an opinion on the manuscript, an analysis on the manuscript, but still the final decision is the editor-in-chief. The ethics of the authors, well, as I said before, the IRB approval is very important, the disclosure of conflict of interest, the criteria of authorship. Remember that the authors need to be involved in the drafting, in the acquisition of data, in the inclusion of patients, in the revision of the final draft, and also in the approval of the final draft. Remember that the authors don't need to, they don't have to get into redundant publication or plagiarism, because this is very unethical, and they will get rejected their manuscript for doing these types of bad decisions on their manuscript. Also, patient confidentiality is very important. Scientific validity of the results, you need to check on that for the authors so they will be ethical. And what are the ethics for us, the reviewers? I think what the first ethics we can incur is to be submit on time. Submit on time the approval of the invitation and the submission on time of our recommendation. It's very important to do a thorough literature review. I do believe this is the most important step in the review process. It is impossible that we as reviewers know everything, every single detail, every single subject, even if it's even if it's a new technique. Well, we cannot know every new technique available in otolaryngology. So the literature review will give us our direction in our own recommendation. So as I said before, constructive review, there has to be no conflict of interest. If you think you have a conflict of interest, you gotta tell the editor or the editor-in-chief or the associate editor that you will not be able to make this review. You have to avoid bias, and the confidentiality of the manuscript and the information of the authors is very important. These are the tips for reviewers. This is some of them I learned directly from Rosenfeld. He has several videos, very good videos about the review process, and I have learned then from, I think I have like almost, I was making counts on the years. I think I have almost like 9 years reviewing for otolaryngology and neck surgery. And I will say you don't need so much time to make a review. I would say with 2-3 hours is enough. If the review of the literature, it gets really very broad literature review, I will say it could take me like 2-3 days, to be honest. But generally with 2-3 hours is enough. You don't need to make a very long review. With 1 page word is enough. I would say if you really concentrate and make very accurate comments, 1 page could lead you the way with a great review. Remember that the comments need to be brief and congruent. Remember to improve the manuscript. Always look at the flaws and try to fix them if it's possible. Try to help the authors. Every time you run into a manuscript, try to understand the authors, try to tell them how to tell better their research. Check for materials and methods is very important. They are well done. Conclusions should match methods and results, and it's very important because it's a very common flaw. Sample size needs to be enough. Beware of the novel techniques with no adverse effects. Be aware of those. Double check all the data, double check the literature review. And lastly, I will tell you that Publons is a social media where you can get recognition of your work as a reviewer. I think previously in 2013, 2014, we didn't have this kind of social media, and sometimes our work, besides the editorial office, no one knew exactly what we were doing. So if you get into also the social media, you will get recognition. You will get more people to know what are you doing, improving science, as I hope you will do. Thank you very much. That will be all.
Great. Thank you so much. That was a fantastic overview, and I think provides a really strong basis for our audience as they think about the process of peer review. I have to say, I've heard you give multiple talks, but each time I'm still amazed that you can give this talk in English. I absolutely could not give this talk in Spanish. So kudos to you. And I feel like you're such a that we have. So thank you. So we're going to switch gears a little bit next and just talk about peer review for clinicians. Recognizing that most folks that come and are interested in being peer reviewers don't necessarily come from a background of epidemiology or statistics, typically come from a background of surgery. And so we're going to talk about 4 topics. We're going to talk about defining outcome measures, basic statistics, internal validity, and external validity. Now, in truth, each one of these could be the basis for a whole semester course. And this evening we got, maybe like 20 minutes. So I'm going to highlight particularly key concepts and give some relevant examples. And I know that sometimes the quantitative number crunching is often not the forte in the room, but I suspect that everyone here does really understand clinical care. So as we go through, I'm going to draw parallels between study principles and clinical care, so that if you understand patient care, you should be able to follow along with concepts about epidemiology and statistics and hang them on a similar framework. So with that in mind, every patient visit really begins with the same key element. That's the chief complaint. Got to know why they're there, whether it's sinus pain or neck mass or hearing loss or tinnitus, whatever it is. And that focus then forms the foundation for the entire visit discussion. And in the same way, when you're beginning a study and looking at it to try to decide how you want to review that study, how the authors defined a primary outcome. And that's the result measure that the investigator really considers to be the most important. And it can actually be surprising how often a submission really doesn't include that, because it's actually a really critical element. It has very clear benefits. So just to illustrate that, I want to show an example of how to select a primary outcome. So let's say you're looking at rhinosinusitis. You could potentially use Lund-Mackay CT scores looking at imaging. You could potentially use Lund-Kennedy endoscopy scores. You could use a validated instrument like the infamously named SNOT-22, or you could potentially use medication usage rates. So all four of these things are very legitimate things to study when you're looking at this disease topic. But when authors are at the outset of their study, it's often really worth picking which one of these is most important to the manuscript and the study and the patients, because it really forms the foundation for the study design and analysis. And let's say you did pick SNOT-22, you can certainly still measure these other elements, but it's good to decide up front which one's the most important, because when you look at things, doing a study without knowing your primary outcome is kind of like wrapping up a clinic visit and not knowing what your patient's chief complaint is. And so to help understand why that really is and why this really matters so much, I want you to just consider this. So we've all seen patients and families that come in and they start to tell you about one problem. There's this nose. It's a big issue, as illustrated here in this image. But then potentially, maybe they start to actually diverge and they start talking about a whole bunch of other scattered problems. There's still kind of just a fixed amount of time for that patient visit. So in the end, you often end up with a few words about their nose and other things, but it's also all over the place. No one thing really gets addressed in detail. And so it's much better when you stay in this particular situation where there's really just one chief complaint. Then you can actually spend that whole visit getting the full picture of that one specific problem and really understanding it. And when you think about this, there's another concept that can come out relative to peer review from clinical care. And that is this: when you look at these two different patient scenarios, one of them is going to be more likely to yield an error in clinical management. And so that one is likely to be this one, the one with so many chief complaints, because it's so scattered across the board, you really can't focus and get a full story on any one thing from that patient and family. And so that patient may or may not get exactly what they need for you. So when you think about this, it's actually really important to ask this question, which patient is more likely to have an error in management? And it really is this patient who has many chief complaints. And so the key thing to think about is that it's actually very much the same for outcomes. And so when you're looking at your primary outcome, when you clearly define it so that's the key concept here. Define the primary outcome at the outset of the study, minimize the error rate. And so that actually has a statistical representation, and that you can see right here. And that is that if K statistical tests are performed, then the risk of at least one false positive is 1 minus 0.95 raised to the power of K. So in a scenario where maybe you have 10 scattered tests all in the same study, the risk of false positives will actually go up all the way to 40%. So that's actually a really high chance that a study then could have an error. I mean, it's almost like you're flipping a coin at that point. It's practically 50-50. But if you stay focused and have one primary focus in the study, then the risk of false positives, when you look at the standard conventions of thresholds used, it's really just about 5%. So it's better to stay focused on a preset primary outcome that is defined at the outset of a study. So it's just like with clinical care. The scenario with one clearly defined concern is less prone to error. So now, why is it 0.95 here? You might wonder that, like, where do these numbers come from? And, when you think about it, you actually know the answer to this question. Maybe you don't realize you know the answer to the question, but most of the time people do. And that is this. It's really the so common p-value threshold of 0.05. And so, what does that p-value really mean? Well, it's the probability of falsely rejecting the null hypothesis. And so that means that a study can show a difference between groups when in truth, there's actually not really any difference there. So that's your false positive result. That's called a type error. And that means the study is telling us that something's important when in reality, it's actually not. And so the clinical analog to that is like telling patients that they have cancer or they have COVID or some other disease process, and they're actually fine. Maybe cause a big fuss, but wrongfully so, really, if you did that, because the patient doesn't actually have that particular disease state. And so your study can do the same thing if that same false positive risk isn't avoided. So you got to think about the paper and whether it's defining that primary outcome up front and therefore trying to minimize the error rate. And it's important to do that because when you're defining the primary outcome up front, it not only decreases your false positives, but it can actually also decrease your false negatives. And it does that in the same way that when you know your patient's chief complaint, it actually tells you what's important to think about if you complain of sinus pain. Well, you want to know about nasal obstruction and runny nose, and what does the drainage look like if there is a runny nose. But if, let's say, the chief complaint was otorrhea or an ear problem, then you might want to know about other things like ear pain, maybe even facial nerve function, things like that. So just like knowing that chief complaint helps you determine the path for your history of the present illness, defining your primary outcome really lets you hone in on very key aspects of your study design. So first, you can think about the measure itself and what its potential properties are. So you typically want to know the range of potential scores, whether it's a validated instrument or an objective measure or otherwise. You want to think importantly about what is a clinically important difference. So for example, let's say we're looking at SNOT-22. That SNOT-22 scale can have a minimal clinically important difference of 8 to 9. And then you want to know, where are you going to set your p-value? Typically 0.05, although if there's multiple comparisons, you might set that a little bit different. And then you want to think about the power of the study, which is 1 minus beta. And oftentimes the power is set at about 80 to 90%. And so, thinking about that power, it's actually really important because you want to change and positively affect the probability of falsely accepting the null hypothesis. And so a type 2 error is kind of like telling a patient that they're fine, they don't have COVID or cancer or whatever it is. And in fact, they do, but maybe they just go off on their merry way and maybe infection is spread, or maybe they die unwittingly of disease that could have really been treated or contained. And so you obviously don't want to make a mistake like that in your practice. So you don't want to make a mistake like that in studies as well. So think about that as a framework when you're looking at these studies also. So one additional thing is that once you happen to know these 4 things, you can actually figure out an appropriate sample size, and it's typically done with a statistician on hand. And if your sample size is adequate to support a good power in a study, using these parameters that you've defined, then you can just help to minimize that false negative rate. All right, so defining a primary outcome, it really lets you get that study design plan really well understood with regard to the different items that we've talked about, and minimize these false positives and false negatives. And that's really a key thing that you want to do as you're looking at these papers. Okay, so now as you look at patients and families in the office, and you listen to the chief complaints and the history of the present illness, during that process, you actually also think a little bit about how certain you are about patients' reported symptoms. So maybe patients come in and they're complaining of terrible pain and asking about opioid medications, but maybe you know that there's an opioid pandemic out there. And so you might hesitate a little bit, maybe especially if there's not substantiating exam findings to subscribe narcotics to somebody who comes in, depending on what their history looks like. And so if you see someone, maybe they have a lot of needle tracks along their arm, you might not be so inclined to give out the opioids for that patient because you would appropriately have a set of uncertainty that you're running through in your mind. Whereas there might be other patient demographics where you might feel a lot more comfortable giving out those medications. So just like in clinic, it's really important to have some sense of potential uncertainty when you're looking at data. And so oftentimes one of the best ways to really understand that is the 95% confidence interval. And so when you're thinking about the 95% confidence interval, you want to conceptualize it as what the results would be expected to be in 95% of replications of a study. So it does not mean that the study results are 95% correct. And it also does not mean necessarily that there's a 95% probability that the true value is within that range. But it's still really a great measure. And in fact, our American Statistical Association says that when they're looking at effect estimates, that means like, hazard ratios, risk ratios, things like that, that actually having that 95% confidence interval can actually be more informative than p-values, even though p-values is oftentimes what we hear about so much. And part of that is because that 95% confidence interval really tells you how much wiggle room there is around that reported result and what the related magnitude of the result may or may not be. Because a big 95% confidence interval is more uncertainty, and a tight one suggests more certainty. So also you can think about those limits and what they mean. So if there's a statistically significant positive finding, you can actually look at the lower limit of a 95% confidence interval just to be sure that it was big enough to exclude a clinically unimportant outcome. And then conversely, if there's a non-significant or a negative finding, you can actually look at the upper limit just to be sure that it's small enough to ensure that a clinically important effect wasn't somehow missed. So when you're thinking about uncertainty, it's also a good reminder just to think about your data spread. So means and 95% confidence intervals are oftentimes conceptualized in terms of normally distributed data. But not all data are normally distributed, and that's fine. If that's the case, and you're looking at a paper where you think that would clearly be so, you can ask the authors to instead report a median and a range or an interquartile range. And you can also think about outliers because those can skew the results. And so if there are outliers present, that's actually a good thing for authors to comment upon. So once you know the chief complaint and the history of the present illness, you've thought through uncertainty, the next thing you'll typically do is ask about their past medical history, past surgical history, medications, allergies, family and social histories. And these are sort of rote aspects of that clinic encounter. But at the same time, you wouldn't want to jump in and operate on somebody without knowing these things. And similarly, you don't want to jump through papers without thinking about potential things that could be influential on observed effects. And so you want to think about this concept of covariates. So what are covariates, and why really bother thinking about them? Well, so covariates are additional variables, oftentimes called the third variable, that they're not the exposure, they're not the outcome, but they could still potentially influence the results that you see. And so not thinking about covariates is kind of like jumping in and operating on a patient, and maybe they have a bleeding diathesis or an immune system problem, or maybe they have active angina or a psychosis. You could actually really run into trouble and have problems if you ignored some of these key things within the history. And, if you instead are just aware of them, you can actually kind of preempt those issues just by thinking about how to address them up front. And that can sometimes be something that you can really help authors with if they're not as aware of covariates. So the issue with covariates is that they can be potential confounders, and these potential confounders are related to the outcome and typically in terms of prognosis and susceptibility, but they're also related to the exposure. And so they can make a difference as they come in to the study. So a potential confounder also has a different typically distribution in the groups that are being compared. So like let's say you're looking at survival. You might see maybe more males, or maybe there's older people, or maybe there's tobacco users, or maybe there's COVID exposures or things like that, more so in one group than the other. Those risks are then imbalanced between the groups. And so the groups might actually then turn out differently even before you introduce the variable that you're interested in terms of treatment. And so when a covariate really has these properties, you really want to think about it and how you can help in a study design where you could address them. So there are a few different ways that you can adjust for covariates. So first, you can randomize, and that's why randomized controlled trials are oftentimes considered so high in the literature and the levels of evidence. And so if you do see a submission come in and it has randomization, you want to take that submission a little bit more seriously than some submissions that you might see otherwise, because they should automatically balance between groups. So another thing that you might see in submissions is this concept of restricting. So that means you take out anybody who is affected by a confounder of concern. So, nobody with COVID, or nobody with tobacco use, or nobody with malignancy was allowed in the study of survival. So that can oftentimes mean like a little bit of a smaller sample size though. So you kind of got to balance that against the power issue that we talked about earlier. But keep this one in mind, because this is something that you might actually suggest for authors if you think that they have potential confounding. It's kind of too late to go back and maybe randomize. They might do an analysis where they present some restricted data. So third, you can adjust for potential confounders in a multivariate analysis. And that does typically require a statistician or an epidemiologist and some understanding of causality. But oftentimes you can find somebody who can help with that if you're less familiar with running some of these statistical models and things like that yourself. Oftentimes there is a friendly neighborhood epidemiologist or statistician. And if you don't have one locally, think about resources within the academy. One of the great things about being in a fantastic professional organization like the academy is that there are groups where they tend to cluster folks who have certain types of expertise. And if you look within, whether it's an editorial board or a journal reviewer group or groups that have specific expertise in evidence-based practice, you can oftentimes find folks who can help with some of these roles. So, we're thinking here about covariates and how we might handle them. The clinical analog here is, we often call colleagues for consults, and we don't hesitate to do that. We would not give radiotherapy or chemotherapy ourselves. And so it's the same with studies. If you're at a stage, there's something that's in there, it's okay. You can ask for some input from an epidemiologist or a statistician. And if you're an early reviewer in the process, if you're a resident in the program, oftentimes your mentor may have some of those skills. And if you're an author in the process, then oftentimes your reviewers or your associate editor may have some of those skills and actually convey certain directions within the review. And just like Dr. Celis mentioned, it's not just about sort of critiquing it, it's about also trying to improve the manuscript. We want to improve science. And even if you're rejecting it, you want to give them an opportunity or a direction to where they might go. So another thing that we can think about when considering covariates is this concept of effect measure modification. And that really occurs when there's a presence or absence of a covariate that actually changes the effect of exposure. So for example, exposure to tetracycline in kids can result in darkened teeth in children, but not in adults. And so for tetracycline usage, age is an effect modifier of whether that antibiotic could have an effect on teeth coloration. And you can oftentimes, assess for this via stratification with a multiplicative variable or a model. And so another key covariate is time. And so things can really change over time. Like the ICD system or diagnostic criteria, time can really be a key factor in survival analyses. So I hope you can still hear me. I'm getting internet unstable, so hopefully there's not a lag. We have, talked about various things, thinking about outcome selection and basic statistics. And in doing so, we've really thought about key elements in study design and methodology. And that's really like what you're doing when you're thinking about peer review. Especially you're thinking about internal validity, which is about the right outcome selection, right methods, the right study sample, and some statistics. And so, as we've talked about this, as you look through and care for patients, you can really follow a very similar line of thinking to try to understand what's important in the study design. Just like you rattle through easily the chief complaint, the HPI, thinking about uncertainty and the sort of more rote history elements, you can really hopefully start to rattle through some of these other things as well. Primary outcome, the various aspects of it, uncertainty measures, covariates, and maybe getting into some complex statistics and epidemiological measures. It's actually a really great checklist of items to consider for internal validity. And Dr. Celis-Aguilar has already alluded to this resource, and you'll see this resource in your training materials if you are matriculating into the resident reviewer development program. And it goes through various things to consider when you are thinking about internal validity. And so our time is limited today, so I can't get into all the details of each one, but I definitely would advocate this as a great reference. And so, the other thing to really think about is external validity. And that's really about making sure that your study's of use to the next person. You want to really describe that internal and external validity in good detail. And so when you're looking at these papers and reviewing them, you want to really make sure that that's very well established in the methods, because then you really know who the results can be applicable to. The other thing with external validity is to think about the intervention in detail. So it's not just, hey, I did this type of surgery, or hey, I gave this kind of medicine, but it's, I did this type of surgery, this was the technique I utilized, these were the instruments, or this was my medication dose, and this was the duration. You want to really make it so that somebody who picks up that paper could replicate that exact same process if they wanted to try to put into practice what was in that paper. And then you also want to think about adverse events, because they don't always come up sometimes, especially in some of the more formal studies that are done, especially if the sample sizes are a little bit smaller. So you want to make sure that the authors are thinking about both the pros and the cons of an intervention or other element that they're studying. And the other good thing about this is it helps this paper to build the next paper, because it can help them build their methods when they understand the results of a paper that is published. And it can also help this paper potentially be included in a future systematic review or meta-analysis, because the methods are very clearly delineated. So, getting back to our clinical care analogy, this is really like making sure that you document your visit in a really good note. You want to make sure that the next colleague that comes along and sees that patient, whether they're on call or the patient moves to another state or whatnot, really can understand exactly what you had in mind as you were treating them. And so think about that aspect as well. Likewise, there's a nice checklist for external validity in that same reference that I mentioned as well. So, in summary, we've talked about defining outcome measures, basic statistics, internal validity, and external validity. And we've really done that with this context of thinking about our regular old remote clinical care key components and how those can align with the key components and study design. And so what I hope this can give you is a framework so that as you approach these studies from the lens of the clinician, you can think about the key elements in a similar way. So thank you very much for your attention today. And we'll at this point now open the floor for questions. So looks like we have a question from Hanane Abdelkrim, and apologies if I've mispronounced your last name. It says, thanks for the presentation. Presenter Erika, what about presentations for a case report with introduction, observation, discussion, conclusion? Your presentation is in case of a study with methods and results. So Erika, I'll turn this over to you.
Thank you. Thank you for the question. I will say that you're totally right. I mean, case reports will only have introduction, case report, and discussion. Actually, they don't have an abstract even. But what I'm allowing myself to read to you is what the Otolaryngology submission guidelines exactly say. This is a case report should need to be unique, highly relevant, and educationally valuable case, very valuable case in order to be published. So if exactly it's just introduction, case report, and discussion, but if you see this case has several cases of the same topic already published, there's no interest for the journal to publish these type of cases that are really repeated in other journals. It has to be very unique and valuable. And it's kind of like more the literature review I was saying previously in my talk. You need to do a thorough literature review of that particular case report and see if it's unique, if there has inconsistencies, or it provides something different from the other reports, case reports, and it will be valuable for the journal mission. Remember, the journal mission is to provide clinical care and with the best available evidence.
Great, thank you.
Dr.
Go ahead.
No, go ahead yourself.
No, I thought that was a great explanation. Thank you for that. So there was also a question about providing a link with which Corinne Ever With It has already done. So if you would like a link to how to register or express interest as being a reviewer at the journal, and you're not matriculating into the resident reviewer development program still, if you are a resident, you have to complete the program before you can be a formal reviewer for the journal. But if you're in our international audience and you're interested in being a reviewer for the journal, please look in the chat and see the link that Corinne has placed there. Any other questions from the floor? All right. So if one does come, you're welcome to put it in the chat of the Q&A. Otherwise, I'll start to wind down our session today. And so today we've done the introductory session. As mentioned, we do have an ongoing curriculum. The upcoming 2 sessions are about international publishing and avoiding predatory journals. And then the next session is about key concepts in statistics. And in particular, it's really going to delve into how do you look at regression modeling and how do you figure out if it makes sense if you're trying to review a paper. We also have other installments in the series to follow, and you can look forward to those announcements in the website and otherwise. So as we come to 7 o'clock, I want to thank you all for your attendance today. We are definitely very excited to kick off cohort 6 of the Resident Reviewer Development Program for our journals. We're also always very keen to welcome our international authors. And so I will bid you all a good morning, good afternoon, good evening, and good night. And thank you all very much for joining us today. Thank you for a wonderful presentation from Nigeria. We're so glad you could join us. Thank you, thank you. Raisa and Iowal, thank you. All right, everyone, have a great evening.